Assalamu alaikum wa rahmatullahi wa barakatuh. Last lecture, I presented to you the concept of pain and how pain is conducted, the different types of pain and different classifications of pain. And we started talking about the dental pain and the changes that occur in the pulp. Now, in this lecture, which consists of two parts, in the first part I'm going to present to you the possible pulpal diagnoses, how they are presented clinically, and the possible periapical diagnoses. So starting with the possible pulpal diagnoses. So the first option, or the first condition is having just a normal healthy pulp, and in this case the patient definitely is not going to complain of any symptoms. There is no pain, no sensitivity in the teeth, and if you take a radiograph, you would not find any changes in whether in the dentin or in the periapical area or the surrounding area of the teeth. If you decided to conduct a pulp or a test or a vitality testing, I usually prefer the endo eyes. The endo eyes has the advantage of telling you whether the tooth is vital or non-vital. So if the patient responded to the cold test, and here it's very important to clarify to the patient if he is going to feel cold or not, cold sensation or not, because the common mistake that students do is to ask the patient whether you feel pain or not. So the patient would feel the sensation of cold, but he's waiting for the pain sensation as you told him. So it is very important to be clear to the patient that I'm going to put something cold, so like ice cold in your tooth, and let me know when you feel the cold sensation. So if the patient managed to feel the cold sensation, this means that the tooth is vital. The other piece of information that an endo ice would provide is whether the pulp is inflamed or not. So if the pulp is healthy, there's no inflammation in the pulp. When you put the cold sensation, so the patient tells you that he feels this cold sensation, and when you take it out, when you remove the cotton pellet that has this ice on it, when you take it out, this sensation would disappear. So there is no prolonged sensation of cold sensation. There is no exaggerated response to the cold sensation, and this is how the normal tooth respond to a cold test. If you do a percussion test, the tooth again is not tender to percussion because the periodontal ligaments surrounding the tooth are healthy. So this is how a normal healthy tooth would be presented in the clinic. Of course, the patient is not gonna come complaining of a normal healthy pulp, but this is the baseline that I want to start presenting to you. And let's compare the findings when the pulp condition change. The second condition that the patient might come to your clinic complaining from is reversible pulpitis, or the presence of hyperemia, where the blood vessels are dilated. There's an irritation to the pulp, probably a Caros lesion, bacteria that are invading the pulpal tissues. So there is an inflammation. This inflammation is still within the repair. There is still a chance for a repair and for it to return back to normal. This is why we call it reversible pulpitis, that we can reverse the condition back to normal if the stimulus or the irritant is removed. So how is this presented clinically? The patient usually comes to the clinic complaining of severe pain, the severe, very sharp pain, electric shock pain, stabbing pain. So all of these are descriptions the patient might use to describe to you the pain that he feels. And this pain usually triggered by a stimulus like eating something sweet, eating something or drinking something cold or hot. So all of these would stimulate the pulp, and once the irritant or the stimulus is removed, the patient, it will subside. So it would not last long. So this is how the patient describes his pain, and this is why we rely a lot on taking the history of pain, because it gives you, the clue of the diagnosis. The problem of this pain, as the nerves that feel or transmit this pain are located within the pulp. So these nerves, they are all joined in the same trunk. Like, for example, the molar teeth, the upper molar teeth would all join in the same alveolar nerve, and then the maxillary nerve of the trigeminal. So there's no way to locate the pain. So it might be confusing, and the patient would tell you it's the whole side that hurts. He cannot specify whether it is upper or lower. A very important thing that you need to pay attention to is sometimes the patient would tell you that I feel this pain, which is like sharp spontaneous pain, sharp provoked pain when I drink something cold, and then it disappears. So this would give you a clue that this is a reversible pulpitis, and he would tell you that, and it is this tooth that caused the pain. He would specify to you which tooth. Here it's very important to know that this is what a patient thinks. Usually patients relate this pain to a cavitated tooth, and sometimes to a remaining root that there's no chance for it to have a reversible pulpitis. The pulp is dead, it's just a remaining root. So sometimes the patient volunteer to specify to you the tooth that might induce the pain. So this might be correct if it is, like, for example, the only carous tooth in the area, or in the arch, or in the jaw, and sometimes it's not. It's just what the patient feels like, that this is the tooth. So here, what I want you to take care of is when the presentation of pain are typical for reversible pulpitis, do not rely on what a patient tells you about the location, because this is not accurate. This is the patient's own interpretation of the pain source or of the pain cause, which might not be correct. So you need to rely on your objective findings, examination, to be able to determine which tooth that is painful. And of course, the treatment here, all what you need to do is to remove the cause of pain, which is usually carous tooth, recurrent caries, maybe sensitive tooth related to loss of tooth structure or abfraction or exposure of the root surface. So you need to deal with the cause, and there is obviously no need to do any root canal treatment because the pulp is vital. And once you remove the cause, once you treated the problem, things will go back to normal and the tooth would heal. And the pulp would heal and go back to normal. The second stage, or if the carous lesion was not treated, the problem is that this caries or these bacteria will go deeper into the tissues, into the dental tissues, reaching to the pulp, and there it will, start to create a severe inflammation. And with a severe inflammation, there is lots of vasodilation, lots of blood is coming in to the pulp tissues, lots of inflammatory cells are accumulating in the pulp tissues, and the patient will complain of severe pain. It's the worst pain. The patient might complain because of the compacted and non-yielding walls of the pulp. So this would induce great pressure and a huge amount of pain. Now this pain is actually, or usually it is spontaneous, so it does not triggered by, or it's not triggered by cold or any other sensation. Now sometimes being excessively responsive or sensitive to heat stimulation, this would indicate irreversible changes. And sometimes without any stimulus, all of a sudden the tooth start, pounding with pain. Usually the pain is of pulsating type of pain because of the it's a vascular in origin. There's accumulation of blood within that limited space, and the patient might feel sort of a throbbing pain. One mistake, or one common mistake, let's say, is the students rely on the fact that it disturbs sleep. Well, it does. It does disturb sleep if the problem happened during the night. But if the irreversible pulpitis happened within the day, so it will disturb the day activity. So the patient would not be able to concentrate in the lectures, would not be able to do, the homework, the things that he usually does. So it disturbs whatever activity you are doing. And if the inflammation subsided, you can go to sleep. So do not rely on the fact that it is disturbing your sleep. It disturbs whatever you are doing because the pain is so severe. And if you decided to do a vitality testing in the clinic and you applied this cold sensation, the patient would feel sharp, very exaggerated response. But the problem, or the way I knew that it is irreversible, because when you remove this cold test, the patient will continue feeling this pain bounding for a while, like couple of minutes or maybe longer, maybe 10 minutes, just bounding with a severe pain. So this is an indication that the pulp is irreversibly inflamed. If you took a radiograph, well, this is here. It shows us what happens inside, what happens in the pulp. There's excessive vasodilation, lots of lymphocytes, neutrophils, and maybe microabscess started to form at certain areas, which is a collection of dead bacteria and dead macrophages and neutrophils. Okay, so we will see a radiograph later. This showed us the chronic irreversible pulpitis. So, do all patients go through the acute irreversible pulpitis? Is it necessary that when you see a remaining root that the patient went through this story of acute severe pain that disturbed the patient's life for a couple of days before the pulp become necrotic? No, it's not a must. Many patients goes into chronic irreversible pulpitis, where the pulp inflammation progress so slowly that it does not yield and does not form this massive amount of pain and this massive amount of inflammation. So still the pulp is irreversibly inflamed, which means that it is beyond repair. It will never go back to normal and it should be removed. However, these changes took place slowly and gradually, and usually you will see there's lots of reparative dentin because it's sort of protective mechanism, and it's the pulp still trying to maintain its life, although it will not go back to normal, but he's okay with his situation, and all what the pulp needs is just to survive. So the pulp tries to confine the inflammation, get itself away and far from the irritation by laying down more and more reparative dentin, as you can see here. So here are the source of irritation. These are the dentinal tubules where the irritants, where the bacterial toxins come to get to the pulp, and the pulp tries to protect itself by laying more and more dentin. When we take a radiograph in a case of chronic irreversible pulpitis, we might not see much actually. We might not see much in the periapical area. Well, what I can see here is some sort of hypersclerosis. And this is sort of protective measure as well. So, and here you can see that the pulp is not showing here because of the too much reparative and tertiary dentin that laid down, trying to protect the pulp, and the whole pulp might be just completely obliterated with sclerosis. So here we cannot see the pulp because of the tertiary dentin formed, and here is small pulp. We definitely cannot see the pulp chamber, and there are no periapical changes. All what we can see is hypersclerosis. So hypersclerosis can be seen in cases of chronic irreversible pulpitis. And in cases of acute irreversible pulpitis, when the patient come to you complaining of severe pain, that he couldn't sleep, couldn't talk, couldn't do any sort of activity because of the severe throbbing pain in his tooth, when you take a radiograph, in most of the cases you would see nothing on the periapical area, because the whole problem is just confined within the pulp. This is one of the main questions that you will have, is to have a clear clinical description of irreversible pulpitis, whether acute or chronic, and to have a radiograph with absolutely no periapical changes. So the answer should be chronic or acute irreversible pulpitis based on the clinical scenario. Do not get confused with having a normal radiograph without any periapical changes, because with irreversible pulpitis or with reversible pulpitis, the problem is still within the pulp. There's absolutely no changes in the periapical area. Now, in this case, although there's no changes in the periapical area, the treatment would be root canal treatment if the tooth is restorable, and if the tooth is badly broken or in very bad shape, extraction should be done. And there's obviously no urgency in the treatment because there's no symptom. This is in case of chronic irreversible pulpitis. While in acute irreversible pulpitis, obviously it's a case of emergency and because of pain, and should be treated with exturbation or extraction. This is a special case of chronic irreversible pulpitis, where the child is young and there is lots of blood supply to the area and the tooth is badly broken. So all of these criteria must be present for a pulp polyp to form. Rich in blood supply and massive destruction in the tooth structure that would allow the pulp to grow. So here the pulp was irreversibly inflamed, but it was not confined within the pulp chamber. So there was a chance for the pulp to swell, exactly as what happens when we have inflammation in the hand, where the skin is loose and can swell. So here in this case, because there's no confined walls of the pulp chamber, as the tooth is badly broken, so here swelling can happen. No necrosis would take place because there's no pressure on the pulp tissue, so the pulp can swell, and we will see it clinically as it is shown here as a pulp polyp. So we call this a pulp polyp. And this is another case of a pulp polyp formed after trauma affecting the central incisor. And if you take if we looked at it in histopathology, we can see here the inflamed pulp, lots of inflammatory cells. So obviously this pulp is irreversibly inflamed. This cannot get back to normal. And you can see here epithelial lining. And this epithelialization happens from the sloughed epithelium that occurs in the saliva, in the mouth. So these epithelium or these epithelial cells would accumulate on the surface of this pulp polyp and forming the pulp polyp as you see it. The tooth is not actually mainly painful, but this polyp is sensitive because there are nerve fibers here and the pulp is still vital. So when you touch it, it is painful, and the patient usually avoid chewing on that tooth because the food would press on that pulp polyp and this would induce pain. And because of the inflammation in the pulp, it is highly vascular and it bleeds easily. So if you try to probe, it will bleed. So the pulp is vital, but it is irreversibly inflamed, and you can see it in the clinic. The treatment, again, if the tooth is restorable, we'll do RCT, and if it is not, we will do extraction. Many cases would require extraction because the tooth is usually badly broken, as in this one. Okay, necrotic pulp. When it is safe and correct to say a necrotic pulp? You can say the pulp is necrotic when there is absolutely no symptoms, no pain, the patient is not complaining of any pain, there is no periapical inflammation, you took a radiograph, there is no periapical changes, so definitely there is no periapical pathology. The pulp is definitely not vital. When you did or when you do a pulp testing or endo eyes, for example, there is absolutely no response. So in this case, it is safe and correct to say necrotic pulp. If there is symptoms, then there is pain. You need to specify whether the pain is related to reversible pulpitis or irreversible pulpitis. If you notice signs of chronic inflammation, like mild pain, some changes like hypersclerotic changes, you would say that there is maybe chronic irreversible pulpitis. But if there is absolutely no symptoms, absolutely no changes, you would say necrotic pulp. Necrotic pulp can be presented as you can see here, just discoloration. There is discolored tooth, and usually this is induced by trauma. So when you see discolored teeth, just ask about the history of trauma. There is a reason why the pulp died in that tooth. If you cannot see caries, so check for trauma. The tooth could be crowned, could be just, as I said, maybe a normal, healthy looking tooth if the trauma history was recent, so they didn't have time to change the color of the tooth. So when you do, there's no symptoms, no sensitivity, no changes in the radiograph, and when you do pulp testing, there is no response. This is the only case that you can state the pulp is necrotic.